Evaluation of large fluid resuscitation in critically ill septic patients. Nothing to disclose. Novant Health is a not-for-profit integrated healthcare system. Our largest facilities are in Winston-Salem and Charlotte in North Carolina. Our intensive care unit delivers specialty care in neurosurgery, cardiology, and to the general medical population. The use of IV fluid remains the cornerstone in the management of sepsis, with a guideline recommendation of at least 30 milliliters per kilograms of crystalloid fluids within the first 6 hours of sepsis presentation. The most commonly used IV fluid is normal saline. However, due to its high chloride content, it's been associated with hyperchloremia, acidosis, and acute kidney injury. Other available fluid options include balanced crystalloids, such as Isolite SPH 7.4, which has a lower chloride content compared to normal saline. Here is a depiction of the difference in chloride content of fluids. The chloride content of Isolite S is about 98, which is comparable to human plasma level. There are a number of studies evaluating the impact of normal saline in comparison to balanced crystalloids, and the results remain controversial. A retrospective study did show a reduction in in-hospital mortality. However, findings from a meta-analysis suggested no difference. The Annals of Intensive Care recently released an article highlighting the need for studies focused solely on septic patients. Due to the large need for volume resuscitation and the disposition to higher lactates, the chances of worsened clinical outcome in response to chloride leach solution are higher in critically ill septic patients. Therefore, our research serves to expand on previous studies by comparing these effects. The primary objective was to compare peak change from baseline in chloride level within the first 7 days. Secondary objective was to determine the incidence of non-anion gap hypochloremic acidosis, assess the need for new renal replacement therapy, determine the total volume of resuscitative fluid, assess the cumulative incidence of acute kidney injury, in addition to other secondary objectives noted on this slide. This was a retrospective chart review on patients who had received fluid of interest within January 2017 and August 2019. For our statistical analysis, we used the paired sample t-test and descriptive analysis. We included patients 18 and above, diagnosis of sepsis, and at least 30 milliliters per kilograms within the first 24 hours. Excluded patients with end-stage renal disease and history of kidney transplant. Of the 802 patients who had received Isolite S within the specified time period, only 28 met the inclusion criteria. We defined the balance group as patients who received Isolite S with or without normal saline, and defined the controlled group as patients who received exclusively normal saline. For our baseline characteristics, both groups were equally balanced in regards to demographics, kidney function, and comorbidities. No statistical difference. Also, both groups were equally balanced in regards to drug exposure within the first 7 days. However, we found more patients in the balanced group required mechanical ventilation, and this was statistically significant. The peak change in chloride level was 9 in the baseline group and 10 in the controlled group. The baseline chloride level was a 101.7 in the balanced group and 99.3 in the controlled group. However, both weren't statistically significant. The total chloride level did err towards some degree of hyperchloremia in both groups. Again, not statistically different. Lastly, patients in the control group received a chloride level of 676 and about 551 in the balance group. This difference was statistically significant, and this translates well into earlier slides that showed normal saline having a higher chloride content. We did further analysis that showed no statistical difference in the total volume of fluid resuscitation between the groups. However, the ratio of isolate S to normal saline in the balance group was 2 to 1. So I think this was a good representation showing that we were able to maintain isolate dominance in the balance group. There was no statistical difference in non-anion group hypochloremic acidosis, length of ICU stay, need for new renal replacement therapy, and ICU all-cause mortality. However, we found a statistical difference in peak change in serum creatinine, about 0.9 in the control group and about 0.29 in the balance group. For our strength was a multi-centered study. We had a diverse patient population due to the makeup of our critical care units. We clearly defined endpoints to maintain consistency across the groups. For limitation, although we utilized the second most commonly used fluids in our institution, we still weren't able to gather a large sample size. Also, the crossover of groups with both the balance group and the control group having normal saline. Our study's design was also a limitation, with it being a retrospective chart review. There was no significant difference in the incidence of non-anion gap hypochloremic acidosis. However, we found that the control group had a statistically higher peak change in serum creatinine. Due to the sample size, we're unable to determine if this translates into clinical significance, because we found patients in the balance group needing more mechanical ventilation. There could have been a potential selection bias from our providers. For future directions, we definitely need larger randomized controlled trials with clear delineation of patients in normal saline versus isolate arm. In summary, the use of at least 30 milliliters per kilograms of fluid is recommended. We have other balanced crystalloids that could be alternatives, and we hope to see larger randomized controlled studies helping to describe the benefits. Here is my objective, and question is, which is not a potential adverse effect? Reduce hospital stay. I would like to thank my project advisors. I look forward to receiving your questions. Please send to email below. Thank you.